Welcome to Health for the World's Grand Rounds on June 16th, 2023. I'd like to give a special congratulations this morning to three of the first radiology residents to graduate from Zambia. That is Dr. Sarah Nshimbi, Dr. Lena Lambert, and Dr. Juliet Mulapwe. And I believe they're the first ever locally trained graduates at Zambia. So special congratulations to them. This morning, we have Dr. David Cheng joining us from the Department of Nuclear Medicine at Jacobi Medical Center. And he's going to be talking about basic understanding of PET scanning for a clinician.
Okay. Well, thank you, Dr. Brown. And I want to thank all the organizers and, of course, my chairman who introduced me to this great forum to share, our learnings and education and help others to understand, all the different modalities in radiology. So I will start. I have nothing to disclose. So I don't know if that's a requirement or not, but I have nothing to disclose. Okay, so I wanted to give a little bit of a brief timeline, and some of this involves mentors I've had over the years who taught me about PET scanning. So this is by no means exhaustive, and I hope I'm not excluding any major contributors to the PET scanning technology. But back in 1973, Dr. Pagosian's team have really made major impact on PET scanning at Washington University in St. Louis, Missouri in the United States. And two of his doctoral students, Michael Phelps and Edward Hoffman, actually were my teachers when I was at UCLA doing my PhD. And they really took the time to teach me about PET scanning and help shape me to the clinician that I am today. So I'm very grateful for that. And so in 1977, one of the first body PET scanner was introduced. And in 1998, Dr. Mike Phelps was recognized with the Fermi Presidential Award from the Society of Nuclear Medicine. In the year 2000, the PET-CT scanner was introduced by Dr. David Townsend and Dr. Ronald Nutt in Tennessee. And so with that, I will launch into a little bit of basic science and clinical. So what is positron emission tomography? Well, positron is an antimatter with a mass of an electron, and it is ejected from a nuclear decay. And when it meets an electron in the neighboring space, then it annihilates, and it gives off two 511 keV photons that can be detected. These are photons that are emitted from the nucleus. So, these are photons that are annihilated from the positron that was emitted by the nucleus. So they're called coincidence photons, and they are separated by 180 degrees apart. And so you can do coincidence imaging, which is superior to single photon emission tomography for reasons that you can eliminate a lot of the stray cosmic rays and things like that in the environment. So your imaging can be much cleaner and less noisy. Now, in order to detect these being 511, you need denser crystals. And so the bismuth germanate was introduced, and then later on by the lutetium base and the gadolinium base crystals, which have other advantages, which we'll go into in a little bit. So because of the annihilation event, you have two coincidence photons, and they each about 511 that we just discussed, and they go approximately 180 degrees but please note that the positron, which is a beta positive, travels a certain distance from the nucleus of origin before it meets a what we call a beta here, but it's really an electron because the difference being electron is from the electron shell, where the beta particle is from the nucleus. But it's basically a negative charge with equal mass, so we really should have an electron here. And so there is some distance that can be between 1 to 9 millimeters, and reminding everyone that the diameter of a red blood cell is only about 8 to 10 microns. So these are several cell layers. So the accuracy of the event that actually from which it took place is not so accurate. It's between, you can have an error up to 9 millimeters. That is usually not a problem because organs are fairly big. But if you're talking about the periphery and you're trying to see if it's within the capsule, outside the capsule, that can be a little tricky. And so just keep that in mind. So the detector evolution, as we mentioned, has started with the very basic sodium iodide crystal, which was used for single photon emission tomography, just for to demonstrate the concept. And that was used in Mass General Hospital in 1953 for brain tumor imaging. Then later on, the bismuth germanate crystal, which is much denser than the sodium iodide crystal, was able to capture a bigger fraction of the 511 keV photons. And then it gives off good light output. And so it was a good crystal that was used for a long time. When I was a student, I was learning from the bismuth germanate. And then later on, they went on to a faster crystal, which is a lutetium based. And that has the technology, or the potential, excuse me, to use the technology at time of flight, which we'll go into in a minute. So here are some old photos I was able to find through the internet. This is from the Journal of Medical Imaging. Some of the pioneers in that. In 1953, Dr. Brownell and Dr. Arnold had demonstrated the concept of using sodium iodide crystals in performing a brain imaging for this patient, and noting that it is taking advantage of the coincidence imaging. So you have two probes basically diametrically, and they were able to map roughly the patient's brain of interest. And I only assume this is metabolism because it's the brain. And they found that they call it unbalanced scan, because the tumor would accumulate more of this radio tracer. And so therefore the location of the tumor will be more intense than the rest of the brain. And so when you do coincidence imaging, you have the advantage of rejecting stray photons, which the single photon emission tomography was not able to do. And so one of these circuits will be that you wait for two coincidence events before you can accept the count. And by doing that, the energy of two 511 keV event would then be additive, and so you can have a bigger voltage blurb. And only when you see these that are above the single event will you then accept the event, and you call it sum. So you can reject a lot of stray photons that are not in order and not expected to be a true event. And so this is, again, from archive. In 1969, Dr. Brownell MGH was starting to make more advancements, and so you have more of a plane rather than just a probe, so you can get a bigger field of view on that. And you can just imagine how big the machinery with all the circuitry, all the wiring and all of that in the early days, and now that has been dramatically reduced in size. So this is a late photo of Dr. Michael Bogosian at Washington University, who was a mentor of my mentors. So I guess he will be in the grandfather figure of my mentorship line of mentorship. And so he, of course, was very active, and my mentors were studying under him doing their dissertation work, and so he did a lot of work in doing that. And so this, unfortunately, is a memorial of one of my mentors, Dr. Everett Hoffman. He was a classmate of Mike Phelps. He unfortunately had passed away, but he was on my dissertation committee, and so I worked closely with him for a time. And so they evolved from having two probes to two panels into a circular geometry of the current day PET scanning. And so this is an ECAT at UCLA early days before my time. And so they were able to have a cylindrical configuration of the PET scanner. And so the advantage of that, of course, is that you can capture a lot more coincidence photons, at a very, very short time, right? Where if you have two panels, the panel has to swing, and so you're losing a lot of photons while your two panel detectors are making its orbit. Okay, but having a stationary cylindrical configuration, you can capture a lot of these photons in very, very short time without having the mechanical rotation of that. So you can capture a lot more with that. So some of the technology, the scintillator, which started with sodium iodide, then went on to BGO, and now to lutetium-based and gadolinium-based. You can reduce the size of these crystals, and you can have some septation, not physical septation, but nevertheless some separation between different detectors. So you can increase your resolution of your images by having smaller and smaller detectors. And this is just again, is from the archive. You can see the depth of one of these detectors. And again, they're septated so that there is less crosstalk from different receptors. And with that, then they went into the difference between 2D and 3D detectors. And the 2D detector, they had septa, physical septa, not just the crystal in the crystal, but physical septa. And that is designed to minimize the crosstalk between the planes. Because even though you have the coincidence imaging, the way we construct is dependent on the linear projection of a certain event. And so when you have a lot of crosstalk, it gets very complicated. Not impossible, but complicated. In the early days, the 2D was favored because the number of crosstalks actually tie up the computer power. And so it saturates some of the detectors, some of the machines, some of the scanners. And so they put in the septa to actually cut down the number of photons that are being detected and accepted at a given time. But as the computer power increased, they realized that they were throwing away or ignoring a lot of the photons that were being emitted at the same time. So they went into what is called 3D. And so they were retracting the septa. So these physical tungsten septa now can be retracted. And nowadays, if you buy a new PET scanner, they don't even put in the septa. And so you can only have 3D imaging on that. And so you can increase the number of photons tremendously, but of course, the computer has to track each of these lines very carefully. Otherwise, when they reconstruct, you will not have a point, you will have many points. And so it is really the progression, the advancement of the computer power that's able to track through all these lines. So this is an image showing a lung nodule in I guess the last generation of PET scanners with 3D, even 3D imaging. And now they have added the latest generation of PET scanner, now introduces a time of flight. Okay, so here you can see the difference in how the nodule looked with and without the time of flight on the same patient, presumably similar acquisition. And so I think we can say that, conclude that the time of flight is desirable because we can see a more clear nodule, on the PET scan. So what is the time of flight and how is it used? The time of flight can be described as the time the photon reaches the detector, and being in coincidence, you can get the time difference between the pair of photons, a pair of coincidence photon reaches to the detectors, okay? And so what is the advantage of that? Well, the advantage is that it will, because of the time difference, you can project back into a fraction of the line along which the photons were originated. Okay, and let me see if I can illustrate here. So without a time of flight, when you have the coincidence event, you will have two photons, and then the computer will register, detector number 455 and whatever 976 or something. And then so they say, okay, there is a line that have the probability of this event taking place, right? And you can reject a certain number of possibilities by knowing where the actual patient borders are. But with the time of flight, not only are you detecting these photons, you're detecting, you say, okay, the first photon detected, the second photon is detected, but the time difference in reaching the first detector versus the second detector will tell me that it is not the whole line, but only a fraction of the line, which is outside the center of the field of view. Okay, the time of flight is less, and some would say render useless if the event were to take place in the very center of the center of view, which may be, but the timing of these are very, very small. They are in the order of hundreds of picoseconds. So what is in the middle to our eyes may not be in the middle for a computer with such computing power. But nevertheless, it is less effective if the event were to take place near the center of field of view, even with the time of flight technology. But most of our lesions, of course, don't read the textbook and they don't behave necessarily, so they're going to be random. And so being the center is a small fraction of the human body, the time of flight is very useful in many, many of the lesions that are not exactly the center of the patient. So having said that, I just wanted to review and kind of drive home a little bit of this 1 to 9 millimeter travel distance. And that has to do with the nature of the positron and the energy of the positron. And these are some of the more commonly used positrons that are commercially available today in the United States. So the rubidium 82 metastable is of course used for cardiac imaging, which our institution is very close to launching. We hope to launch in a few months. It has a half-life only 75 seconds, so we need a generator that is continuously feeding into the patient. And that positron has an energy, kinetic energy of 3.35 MeV. And so that will travel some distance much greater than, let's say, the lowest energy, which is F18, which has a 109-minute, 110-minute half-life. And that energy, the maximum energy, is only 635 mega electron volts. Kilo electron volts. Sorry. So that is quite a distance. So with the F18, which is the isotope for fluorodeoxyglucose, it has a maximum range in water or tissue is only about 2.4 millimeter compared to some of the more energetic, including the gallium-68, which is what we're using currently in the radiopeptide. So you can see that the more desirable is really the F18, but of course, radiochemistry has a lot to do with our choice of which isotope we use. The O15 is only has a 2-minute half-life. I've encountered some of this experience in a different institution, which they have a cyclotron. And like a generator, the rubidium generator, this requires a much bigger generator with a cyclotron. And so it has to continuously produce and feed, and so that we can do the imaging on the patient. And then you have ammonia, which is possibly commercially available. And unfortunately, in the Bronx, that has not been so reliable of recent time. It has about a 10-minute half-life. And so this is also being used a lot in cardiac imaging. The C11 is usually used in many of the neuroreceptors. It has a 20-minute half-life, so it is possible to transport this to a different site, although it is produced by cyclotron as well. And I've had some experience with that with the neuroreceptors. And we have already talked about F18, and the gallium now is in the radiopeptides realm with the dotatate and the PSMA. So another concept is the partial volume effect. And this is one of our publications which we try to investigate on that a little bit. So you can see this is a phantom work. And in this phantom, which will be filled with water, we'll have these spheres. And these spheres are of different sizes. And in these spheres, we have filled the same concentration of F18, we call it F18, but it's FDG, but would have been F18 minus would have been fine because it has no biodistribution here. So this is approximately 5 microcuries per cc. And so each of these spheres, there are different sizes, so the total radioactivity will be different, but the concentration is the same. Right. And so you can see in this particular experiment, we did it for a different reason. But you can see at 0th hour, which has the maximum concentration, not all of the spheres are visualized. These are 3-minute acquisitions using a lutetium-based crystal with time of flight. But even with the best technology, some of the smaller spheres really are not registering. And then we did this experiment to decay like every couple of hours at random. And so you can see as it decays, the radioactivity being captured is less and less. So you may ask, well, this is a nice experiment. What does it mean? Well, you can imagine that when we image a patient, not all the lesions are standard in size. And so we have no choice, right? We don't choose patients of a certain size of lesion before we image. And even if we do, there will be some lesions that are smaller than the 1 centimeter, 2 centimeter masses that we, the primary lesion and things like that. So this is really a representative of a patient with different sizes of lesions. And we just have to kind of understand that we will miss some of the lesions, detecting some of the lesions because the size is too small. And so when we decay these, we are actually investigating, even if a patient of a certain size that you can see, with the decay, we can kind of equate this as the FDG or whatever tracer that we choose, the avidity of that. So you can say that, from here to here, the same lesion size, maybe one lesion, maybe it's a small cell lung cancer that is very FDG avid versus a carcinoid lung lesion that is not so FDG avid. So, you can kind of emulate, that what you will encounter with the different avidity of your radio tracer for the lesion. So what we have been able to reconstruct is the recovery, what we call recovery. We're not the only group. There have been many groups that have put in this effort. We're basically able to duplicate that group, but our publication was not, I don't know why my, okay, sorry for that. So we were able to duplicate a recovery depending on the size of these spheres. Okay, and as you can see, most of us would say, I think in the literature, I think most people would say 1 centimeter, you are doing fairly well, but in actuality, you are not recovering 100%, even at 1 centimeter. Okay, you really want to go closer to about 2 centimeters or higher before you have more to complete recovery of all your activities. Okay, so I was asked oftentimes by pulmonologists, because they're interested in pulmonary nodules before they get to be a mass, before they have to take out a whole segment or even a whole lung. So they always trying to push it. They always say, oh, it's like 9 millimeter, 1.2 centimeter. Is it possible to do an FDG scan? And I would always tell them, I said, well, that would depend on how avid the lung nodule would be, right? And so you can see that under 1 centimeter, you can still detect some of it, but it will not be a true uptake intensity because you're losing some fraction of that due to the partial volume. Okay, but if the lesion is a small cell and it's very, very avid, you have a chance to detect it, and you can detect metastases as well. And so, yes, you can help the patient. So I do not reject such a request. But at the same time, if you have a carcinoid, you may, need to have 1.5 centimeter or even bigger because the avidity is not so hot. And so, you kind of, until you get the tissue diagnosis, you kind of take a chance. But, for patient care, we don't always get to choose. So one of the first, it is the first actually accepted by FDA to a radiopharmaceutical to be billable in PET is 2-fluoro-2-deoxyglucose. And my mentor, Dr. Michael Phelps, did a lot in lobbying to get that done in California. And so after that, of course, then there was a pathway and people were able to, I wouldn't say fast track, but certainly have a model in order to get the other radiopeptides going. So what is this FDG? Well, the FDG, of course, is a deoxyglucose, and it mimics the glucose transport, and then it gets phosphorylated. But because it's missing the oxy group in the second carbon position, it does not proceed any further in the glycolysis. Now, there are favorable characteristics of tumor cells that will enhance its uptake over the basic background physiologic tissue. And one of that is, of course, you have an increase in glucose transporter, as well as the phosphorylation, the first phosphorylation step in tumor cells over normal cells. And so you can kind of imagine you inject it intravenously, and the FDG along with glucose gets delivered to various tissues, and then they get transported by the same transporter, and they get phosphorylated. But with the deoxyglucose, it goes no further, whereas the glucose will then go through glycolysis and then eventually will enter into CO2 evolution with the Krebs cycle and all of that. So just to review, we've all learned these things back in school. Again, you have the glycolysis, and if the tissue has the mitochondria, then you can participate in the Krebs cycle, and then the ATP will then be generated through all of these, but most efficiently in the electron transport chain. So let me go back just 1 minute. So even though the FDG is transported by the glucose transporter, it is only an analog of the glucose, and therefore the efficiency, the binding of that glucose transporter for the FDG is not as strong as the glucose itself. And by having this step to be terminal, the FDG now is trapped inside the cell for a time, because the reverse step, the phosphatase, also takes place, but it's a much slower step. And so for a time, the FDG is trapped. And so you can then distinguish certain tissue types using FDG. Now, glucose, if you are to do that with glucose, which was done, my mentor told me before I got to their school, you can take advantage of the transporter, but once that glucose gets in, it gets burned, right? It gets metabolized. And so the patients need to be very, very close to the scanner. I've heard funny stories where they said, well, because of FDA regulations and NRC regulations, they had to inject and produce the FDG and the C11 glucose, and then they inject it to the patient in some room, and then they have to push that patient as quickly as they can into the scanner. So they said, well, in the younger days they can do that, but as they got older, it gets a little harder. So that is the drawback of reducing the C11 glucose, which they have done in the past. So the FDG is actually more desirable and more practical for PET imaging. So again, you're reminded of this. Now, because of that transporter difference, the FDG does not get picked up as quickly and as well as the glucose. And so from that standpoint, in the kidneys, it does get filtered. The glucose get filtered as well, but the glucose get reuptaken in the proximal tubules, where the deoxyglucose also, but not as effectively. So I always ask my residents, I said, well, you see the FDG in the bladder. Is this patient a diabetic? And, of course, people, you tell people to look and all of that, but they don't always reason all of them, right, at the heart and things like that. And so the answer is no. Every patient, diabetic or not diabetic, will have FDG in the bladder because that it is not reuptaken as effectively as glucose would. So you'll always have some deoxyglucose spilled over into the urine. Okay, so that is a little bit of a trick question, but and you think about bathrooms for the staff and the patient, you have to understand the patient getting PET scans will have radioactive urine. Okay, so that's why in our institution we have separate bathrooms for the staff versus the patients. In this particular example, we can see there are inguinal lymph nodes from that. Okay, so now I'm just going to go through some images to finish up. So these are FDG scans, and you can see there's a lung nodule and also the paratracheal lymph node. Here for lymphoma, you can see there are lots of retroperitoneal nodes. This is a MIP image, so it's all the many of the slices there, and you can see that there are also things in the thorax. This again FDG. This happened to be the right side of the tongue cancer. And this is a rectal cancer, and you can see that it is taken up very well here. Again, FDG. And here, presumably, it could be lymphoma, presumably maybe breast. You can see the internal memory node. This is a melanoma patient, and you can see that melanoma met going into the soft tissue in the pelvis. Okay, so we have moved beyond FDG, and so one of the recent introduction in our institution is the dotatate. And dotatate, of course, is a somatostatin analog. It is for subtype 2. There are many subtypes. The somatostatin is secreted mostly by the delta cells of the islets of pancreas. It was meant to be an inhibitory effect. It was approved in 2016 by the FDA. We are a little bit late to get it, but we were able to get it in 2020. And so it is very good in detecting neuroendocrine tumors, because the neuroendocrine tumors like carcinoid are not very FDG avid. And they often thought they could be benign until they grow a little bit more, and then they biopsy, and then they realize it's a neuroendocrine tumor. So we use a gallium-68 for that, and the gallium comes from, is a daughter radionuclide from the germanium-68. It has a 68-minute half-life. It decays into a stable non-radioactive zinc atom. And now this gallium-68 is then chelated using, I will try to pronounce these names. And the dotatate has actually a much higher affinity of only 0.2 nanomolar. I was trained using the Indium 111 octreotide, which unfortunately has a very, very high background and makes the detection very, very difficult. So when you evaluate these ligands, it's a little different from the FDG because we are talking about really receptor binding. So you remember back in your chemistry days, we've all done equilibrium equations and things like that. And so you can kind of model, I guess model is a good word, what these species may be. Okay, you could easily have done the reverse reaction, you know, a reactant plus another reactant giving you a product. But you know, if you start off with a product which is a bound entity, then you have the dissociation, and you can estimate what that kinetic would be. And that is considered the dissociation constant, okay? And so the dissociation constant is mathematically modeled as free separated species of the ligand and the receptor over the bound, okay? So if you have a very, very small number, which most of these are, remember this one was in nanomolar, nano meaning 10 to the negative 9, you will have much, much greater fraction of the bound entity over the free. So we call that high affinity, right? Because if you put them in the right physiological condition, they're basically 10 to the 9 fold greater in the bound state than in the free state. So we call that high affinity, okay? So that all has to relate into the dissociation constant. So having know that, here are some of the patients at Jacobi. This is the 83-year-old female with neuroendocrine tumor. And you can see that it is in the lung, in the right lung. It is a pleural-based chest wall. And it turned out to be a carcinoid patient, okay? And you can see that it is not very, very hot. I should have put down the SUV on this, but it is not very hot. And you can tell also that the biodistribution is different, okay? It is more the liver, spleen, and the kidneys, okay? A little bit in the thyroid, because you have the parafollicular cells that have the somatostatin receptors, and then of course bowel. Okay, this is the MIP, so we don't have the right slice or the exact slice. It's you know, something here. So anyway, okay, so here is an 82-year-old with the neuroendocrine tumor in the duodenum. And you can see that he picked up very well, again, with the different, not different distribution from the FDG. And so the brain doesn't pick up, but the pituitary picks up physiologically. So you have to kind of have some experience, some training in terms of what you know, you need to see in terms of get your threshold. This is not really a receptor. This is an axumin. The tracer is fluciclovine, which is a synthetic amino acid. It was approved for prostate detection, prostate cancer detection, before the PSMA was approved. And so this is really a non-specific ligand that has the attempt to look at protein synthesis, differential protein synthesis, I should say. I used it. We used it because we didn't have any real alternative to look at prostate until PSMA came along. As you know, prostate is not FDG is not very sensitive for prostate, and so this Axumin was the alternative. Unfortunately, the Axumin, being non-specific, was only approved by the FDA for imaging only for the first 5 minutes of after injection. Okay, because it is a synthetic amino acid, it gets washed out. It gets washed out rather quickly. So what we are looking at in this particular tracer is really the differential or the transport into the cell, but it doesn't really stay in the cell. Okay, so this is a patient, a 62-year-old, who had a prostatectomy, but then was found to have elevated PSA. If the patient were to have a prostate gland, then of course you could have up to 4 nanogram per milliliter. But without a prostate gland, you really should have near 0. And so this, even though it's only 4.35, was deemed to be abnormal. So the trick then is, the challenge is then how low, how early in your recurrence can you use this tracer to say, yes, there is a tumor, or no, there is no tumor. And so for Axumin, it was very difficult, at least for me. Maybe an expert would be much better. But so in this particular patient with a very mildly abnormal PSA, you can see a little bit of uptake in the post-surgical bed. And so, if you have nothing better, you are going to have to call that. And then, of course, you need to do an MRI to see if there's anything abnormal with that. So in this same patient, there was also a left inguinal node that has, again, mild uptake. And we call that abnormal because the right side doesn't really have the symmetric uptake kind of thing. And this node happens to be only about 8 millimeter. So we can understand why the PSA is so low, because the tumor burden is still low at this time. Okay, so when the PSMA was approved by the FDA, we switched over there. Although we do occasionally get some Axumin requests, but then we have been kind of nudging them to go over with a PSMA. The PSMA attempted a long time ago when I was in training in the form of the Indium 111 Prostasint, which is a SPECT imaging. Unfortunately, the epitope is in the cytoplasmic domain. And so the access of the processing to the domain is low. And so you have very, very noisy background. That's the unfortunate part. Well, they've done a lot of advanced experiments and things. And so now the PSMA, there are many, I guess, types of the PSMA out there. And now they are in the extracellular. And so they are able to get that. So the PSMA that we chose was basically a PSMA 11. I'm sorry, my slides are a little bit out of order. I should have put that slide later on. My apologies. Before we go there, we do have the fluoroestradiol imaging for breast cancer with ER positive breast cancer. And this particular patient was one of our first in our institution. And you can see that there are axillary lymph node there. And the primary tumor, of course, was in the left breast. And in this particular patient, there are also there's femoral bone met, which you can see using, and on the CT, I'm not so sure you can really definitely say there was a metastasis in the bone there. It's a different patient, a 59-year-old lady, has bone met in the left ilium. And again, I'm not so sure you can say that there is definitely bone lesion in the CT. Okay. All right. So once again, my apology. Now we're in the PSMA. This particular patient is a 57-year-old with a PSA of 6.7 nanogram per milliliter, the normal being 4. This patient did not have a prostatectomy. So he came for imaging, and we used the gallium PSMA 11. We see it in the right lateral apex with an SUV of 4.9. And we detected it, and then so they went and biopsy it about a month or so, maybe 2 weeks later, and they turned out to be a Gleason 7 adenocarcinoma of the prostate gland. So you can see that it is easier to see than the Axumin. But still, the idea is how low can you push this PSA and still be able to detect. Well, this is another patient who's an 80-year-old, has known prostate cancer. Back in 2010 was a Gleason 6. The patient did not have a prostatectomy. The patient chose to have radiation therapy, and then came back with a PSA of 31.7 in 2022. So we did the PSMA 11 scan in March of 2023, and you can see that there is uptake in both sides of the prostate gland, the left side greater than the other, and with the SUV of 15.5 and 10.5 respectively. And you can also see that the biodistribution is a little different, mostly in the parotid glands, again, kidneys, bowel, ureters, and the spleen and liver. Okay, so that's the end of my slides. The idea here is to hopefully share some of our experiences in the clinic with the radiopeptide, but more importantly, I think there are concepts in basic science that we clinicians may not have always considered and kept in mind when we're looking at lesions. So the smaller lesions, you are prone to the partial volume problem. And so sometimes I would put in a sentence claiming that some of these low intensity in a sub-centimeter lung nodule may be underestimated, so that they are more likely to go after a biopsy before the tumor gets too big. And now with the carcinoid tumors, now we have the dotatate. We can have an alternative that will help us detect these rather than the FDG. Similarly, with the prostate cancer, we have the PSMA now that we can also increase our sensitivity in detecting. Just one last comment. Of course, today we talked about imaging, and imaging is very good diagnostically. But of course, in nuclear medicine, we want to go into therapy. And so there are therapeutic agents for both the neuroendocrine in the form of Lutathera, and of course the PSMA for the prostate. We have the Pluvicto that we are also moving on to, but that would be a different topic. So I hope it has been useful for you, and I will happy to entertain questions.
Yes, thank you, Dr. Cheng. That was a great lecture, and I really enjoyed the history behind it.
Thank you.
Please feel free to ask any questions down in the question and answer tab below, and we'll give some time for that. And again, thank you for the oversight too into PET imaging.
Thank you. Thank you for everyone's time.
Yes, I just took the core exam, and a lot of the physics was coming back from there, and the artifacts and whatnot. So it's definitely good to hear it and hear it explained in different ways. That's always nice. Thank you.
Well, thank you. I mean, I think all of us should keep in mind the limitations of the scanner, and it's always advancing, which is good. But you know, we should not overlook the disease, and which comes in all sizes and shapes and all kinds of avidity that we have no control over.
Great. And it looks like we have a question from Olubukola Olu. Which agent is better for prostate imaging?
Well, I would recommend the PSMA. Of course, there are commercially available, there are several. We choose the Eluxis, which is a PSMA 11, only because the FDA approved the Pluvicto, which is associated with, they both are from Novartis. Unfortunately, I don't want to mention names commercially, but they did the work so that the FDA approved them kind of in association with each other. There are other PSMA agents, which I'm sure will work fine, but we chose it because we wanted to proceed to therapy, and we wanted to stay with the FDA recommendations. That's it.
Thank you. It looks like we have another question as well. What are the radiation risks to the doctor or specialist, including to the technician long term?
So I happen to be on the radiation safety committee. So the long term, I think the community would say that if you stay below a certain level, which is being monitored by your film badges, there are really no high risk long-term effect. But the fear, of course, is being stochastic versus non-stochastic, whether there's an actual threshold beyond which, or it's just a cumulative over lifetime risk. And because our radiation exposure is relatively small in the medical realm, the statistic doesn't really tease it out. So we recognize there's always that potential of the risk, but we want to keep it low, and so we wear film badges, and then we let the community and experts to guide us, you know, what level we should be below and that.
Thank you. Let's see, we'll allow another few minutes for the questions. Oh, here we go. Here's another question. How can we monitor metastasis response to treatment with PET-CT?
That's a very good question. So to look at progress or failure, of course, you need more than one time point. And so you need to repeat the scan. You can always do CT by looking at the anatomy, the size, whether it's grown, shrunken, etc. But nothing will replace either radiopeptide imaging or metabolism. So we use the monitor of SUV, and we use SUV max because the SUV mean it will be too cumbersome for us to make sure all the borders are within the lesion. And sometimes the lesions are irregularly shaped, so it takes too much time in practice to do that. So we look at the SUV max, and I think the Society of Nuclear Medicine recommends you can call it individually, but I think they recommend that you want to see close to a 50% change to say that yes, there's progression or yes, there is a reduction. Of course, you can always give your own opinion on it. But we also know that the SUV can be a little bit influenced by the duration of your biodistribution. In other words, we try to keep it at 60 minutes after injection for imaging, but sometimes things run late. Sometimes the scanner has problem. And so, you may have sometimes doing it in 90 minutes, and then your SUV will be influenced from that. So you just have to kind of use your own judgment, and I'm sure your colleagues will help out with the MRIs and CTs and things like that.
Great, thank you. All right, we should be wrapping up soon. If you have any last minute questions, please feel free to put them in the question answer tab. All right. Well, if there are no further questions, thank you, Dr. Cheng. Appreciated your lecture. And again, congratulations to the, oh wait, we got one more. What would be the cutoff point for infection and tumor?
Oh, that's a very difficult question. People have tried various methods. The early days, we say 2.5, SUV to be suspicious for tumor. Of course, the infection you would expect to be higher. Because it's you have inflammations, and so the inflammatory cells will have metabolism, and so you expect that to be higher. Now, Dr. Aladi has championed the 2-time point, to see if the SUV increase, and for infection, the SUV would be decreased over time. Whereas the tumor, the retention of the FDG seems to be better than inflammatory cells. So they for tumors, the FDG, for the tumors, the SUV will actually increase. Not a lot, maybe like 10-15%, instead of decrease over time. So you could try the 2-time point analysis for your scan to give a little bit more specificity to separate between infection and tumors.
Great, and it looks like there's a comment. Thank you so much for thank you so much. I really enjoyed your talk.
Thank you. Thank you for everyone's time.
Thank you, Dr. Cheng. Again, we'd like to thank Dr. Cheng for providing the lecture. And again, another special congratulations to the first radiology residents to be trained in Zambia.
Indeed.
This lecture should be recorded. This lecture was recorded and will be uploaded in a few days on the Health for the World website if you'd like to rewatch. Thank you for your guys' time.
Thank you. Have a nice day, everyone.